My Hands Are Puffy by Lena Hall. In the comprehensive HPI, the patient is a 74-year-old Caucasian female presenting to the family practice stating, "I have puffy hands." Patient presents with aching joint pain and symmetrical swelling bilaterally. Patient denies any previous history related to trauma or previous treatments to this condition. The patient states that her condition has gotten gradually worse as she has gotten older. The patient then stated, "I thought it was just old age." The patient indicates there was no modifying factors. Severity of conditions has slowly been worsening, and the onset is unknown. She has no known allergies. Now we're going to go over the review of the systems. The constitutional or the general appearance, the patient denies fever or chills, recurrent fatigue or malaise, headache, sweats, anorexia, fatigue or weakness, or weight loss. In the ears, eyes, nose, and throat, the patient denies vision changes, light sensitivity, eye pain and irritation, double vision, vision loss, hearing changes, ringing in the ears, ear pain, nosebleed, nasal discharge, nasal congestion, non-healing sores, sore throat, difficulty swallowing, tooth pain, non-healing sores, or oral lesions. In the cardiovascular system, the patient denies chest pain or pressure, shortness of breath with normal activity, elevated blood pressure, difficulty breathing with lying flat, shortness of breath at night, shortness of breath that wakes you up from sleep, palpitations or sensation of heart beating in your chest, swelling in the ankles, lightheadedness, or weight gain. For the pulmonary or respiratory, the patient reports having a COPD history, denies shortness of breath at rest or with exertion, cough, productive cough, difficulty breathing, wheezing, excessive snoring, shortness of breath, excessive sputum, chest discomfort, coughing up blood, sleep disturbances due to breathing. In the gastrointestinal, the patient denies heartburn or acid reflux, difficult or painful swallowing, nausea or vomiting, diarrhea, constipation, abdominal pain or cramping, bloody or black bowel movements, excessive appetite, loss of appetite, indigestion, nausea, gas, hemorrhoids, and change in bowel habits. In the genitourinary, patient denies painful or difficulty urinating, blood in the urine, frequent urination, incontinence, urgency, incomplete emptying, and hesitancy with urination. In the musculoskeletal, the patient complains of tender, warm, swollen joints. The patient states again, "I have puffy hands." Neurological, the patient denies frequent dizziness, fainting, weakness in arms or legs, numbness or tingling in arms or legs, headache that is new or changing in frequency, difficulty with concentration, memory loss, sensation of room spinning, tremors, visual disturbances, weakness, inability to speak, and seizures. In psychological or psychiatric, the patient denies depression, hopeless anxiety, feeling stressed, panic, obsessing, sensitive, suicidal thoughts, mental disturbances, hallucinations, financial hardship, not feeling safe at home, or social problems that interfere with her mental or physical health. In the physical exam, we will start with the vitals, which the patient had a blood pressure of 141 over 93. Her pulse rate was 86. Her respirations was 17. The temperature was 97.9. Her O2 stat was 92%. Her weight was 97.4 with a BMI of 19.46. Her general appearance, the patient is appropriately dressed. Her appearance is clean and kept. Patient is a thin white female. She does not appear to be in distress, and the patient is alert and oriented times 3. Her neck is supple with no masses or palpable cervical nodes. The trach line is in midline. The thyroid is without nodule, masses, tenderness, or enlargement. The lungs is mildly diminished breath sounds with prolonged expiratory phase and no extra added sounds. The cardiovascular is a normal S1 and S2 with no rubs, no gallops, no murmurs or carotid bruise. In the musculoskeletal, there is joint effusion in both wrists, metacarpophalangeal joints, and better phalangeal joints. The neurologic is grossly normal. For this patient, the diagnostic studies that would be ordered would begin with the labs, which would be the rheumatoid factor or the RF. This blood test checks for RF, an antibody that many people with rheumatoid arthritis can eventually have in their body. Not all people with rheumatoid arthritis test positive for RF. Some people test positive for RF but never develop the disease, and some people test positive but have other diseases. However, doctors can use this test along with other test results and evaluations to diagnose rheumatoid arthritis. The next lab test is called anticyclic citrullineated peptide antibody or anti-CCP. This blood test checks for anti-CCP antibodies, which appear in many people with rheumatoid arthritis. In addition, anti-CCP can appear before rheumatoid arthritis symptoms develop, which can help doctors diagnose the disease early. This test results, along with the result from rheumatoid arthritis blood tests, are very useful in confirming a rheumatoid arthritis diagnosis. However, it is important to note that some people have rheumatoid arthritis even with normal blood tests. The next test would be the complete blood count, and this blood test measures different blood cell counts and can help diagnose anemia, which is common in people with rheumatoid arthritis. Next is the erythrocyte sedimentation rate, often called the SED rate. This test measures inflammation in the body and monitors disease activity in response to treatments. And finally, for the last lab, we have the C-reactive protein. This is another common test for inflammation that can help diagnose rheumatoid arthritis and monitor disease activity in response to treatments. The next diagnostic study would be an X-ray. An X-ray can help check for rheumatoid arthritis. However, they are not generally abnormal in the early stages of rheumatoid arthritis, before joint damage occurs. Doctors may use X-ray to monitor the progression of the disease or to rule other causes of the joint pain. And finally, a magnetic resonance image or MRI and ultrasound may help diagnose rheumatoid arthritis and the early stages of the disease. In addition, these imaging tests can help evaluate among of the damage in the joints and the severity of the disease. An assessment for this diagnosis of the patient, some differential diagnoses that we can encounter could be fibromyalgia, which is a disorder that causes widespread musculoskeletal pain. Rheumatoid arthritis and fibromyalgia share some similar symptoms, including pain, sleep troubles, fatigue, anxiety, and depression. Their causes, however, are very different. Rheumatoid arthritis is an autoimmune disease that causes the immune system to attack the joints. These two conditions progress differently. Rheumatoid arthritis flares up at times and worsens without appropriate treatment. Like rheumatoid arthritis, fibromyalgia is a lifelong condition, but it is not progressive. It does not worsen over time or cause damage to the joints, muscles, or organs. Next, we have Lyme disease. Lyme disease is a bacterial infection from the bite of an infected tick. Early symptoms of Lyme disease are rash, fatigue, fever, and headache. Lyme disease is sometimes confused with rheumatoid arthritis, and both of these conditions become severely worse if not properly treated. Joint symptoms of Lyme disease resolve with treatment. With rheumatoid arthritis, joint symptoms can improve with symptoms, but they can also return. Also, rheumatoid arthritis has no cure. Next, we have osteoarthritis. It's the most common type of arthritis. A primary difference between osteoarthritis and rheumatoid arthritis is the cause of joint symptoms. Osteoarthritis results from wear and tear of the joints, and rheumatoid arthritis occurs when the immune system malfunctions and attacks the joints. Next, we have sarcoidosis, which causes inflammation of the lungs, skin, and lymph nodes. It leads to granulosis, tiny grain-like lumps. People with sarcoidosis might experience chronic arthritis similar to what is seen in rheumatoid arthritis. sarcoidosis joint systems can affect the knees, ankles, wrists, hands, and fingers. Sarcoidosis, blood markers, and chest x-rays can help a healthcare provider distinguish it from rheumatoid arthritis. Abnormalities can be seen on chest imaging in more than 90% of people with thoracic involvement of sarcoiditis. Finally, we have the systemic lupus erythematosus is an autoimmune disorder or disease that shares some symptoms with rheumatoid arthritis. Shared symptoms include joint pain and inflammation and fatigue. Systematic lupus is different from rheumatoid arthritis because systematic lupus affects the skin, where rheumatoid arthritis usually does not. A systematic lupus typically presents with a butterfly-shaped rash on the nose and cheeks, and people with systematic lupus erythematosus are also more likely to experience inflammation of their heart and lungs than people with rheumatoid arthritis. Systematic lupus erythematosus can also cause damage to the kidneys. For a patient with rheumatoid arthritis, there's options for the management of it. We can start with medications. NSAIDs can relieve pain and reduce the inflammation. Steroids, such as prednisone, can reduce inflammation and pain and slow joint damage. Conventional DMARDs, these drugs can slow the progression of rheumatoid arthritis and save the joints and other tissues from permanent damage. Another option is physical therapy. Physical or occupational therapists can teach you exercises to help the patient's joints be more flexible. The therapist may also suggest new ways to do daily tasks that will be easier on the patient's joints. They can also give assistive devices which can make it easier to avoid stressing the patient's painful joints. Next, we have surgery. If medications fail to prevent or slow joint damage, the patient and the doctor may consider surgery to repair damaged joints. Surgery may help restore the ability to use the joints, and it can also reduce pain and improve function. Now, if you're diagnosed with rheumatoid arthritis, it's always common or beneficial for the patient to continue with routine monitoring and ongoing care. Having the patient follow up with appointments with their physician is important so that the physician is able to monitor the symptoms and the systems and help decline the progression and help to lessen the symptoms so the patient is not in pain and they can have a better quality of life. Now, the prognosis in this particular patient and in this case, with this patient, the patient does not appear to have significant inflammatory arthropathy affecting her wrists and hands. She has sausage digits bilaterally with effusion in the MCP joints and the ICP joints. There's also effusion in both hands. Patient states that she does not see a rheumatologist, and she is doing physical therapy, and that is helping her pain. She does not have redness or significant discomfort with palpation of her joints. The patient is having lab work done and x-rays of her hand and wrists and is going to be following back up with the primary care provider to go over the results, and she agreed to have the primary care provider monitor her symptoms. Thank you.